What are some of the variables as a female patient goes through that journey? What are some of the variables that are driving different postmenopausal outcomes?
We're doing this in a discovery manner. One of the factors we're looking at is that we know while we're having success in treating breast cancer patients, we're having earlier diagnosis of breast cancer patients, and women are living longer who are diagnosed with breast cancer. What we're only just really recognizing is that the incidence rate of breast cancer is continuing to increase. It hasn't abated to any extent. So the question is, if we really want to drive prevention rather than just early detection, we need to understand why that incidence is increasing.
Welcome to the Scale Healthcare Technology and Innovation Podcast, where we explore how innovative technology is revolutionizing U.S. healthcare. Hosted by Jason Schifman, president of Scale, we sit down with industry leaders to uncover the strategies, breakthroughs, and technologies shaping the future of care. Join us and subscribe as we dive into the cutting edge of healthcare innovation.
All right, welcome to the next episode of the Scale Community Technology and Innovation within Healthcare podcast. I am joined today by my guest, Michael Liebman, the co-founder and managing director of IPQ Analytics. IPQ Analytics applies deep analysis and analytics to better understand conditions, the causes of conditions, to drive more thoughtful preventative care, just more thoughtful understanding of the different causes of some conditions that so IPQ has spent a lot of time today in women's health, conditions such as breast cancer, osteoporosis, different types of gynecology conditions. So we look forward to exploring all of that in this discussion. Michael, welcome.
Thank you. Happy to be here.
So Michael, why don't we begin with just a quick introduction to your background. You've traveled and seen a lot of the healthcare market from different perspectives.
Yeah, so I started out in sort of a conventional academic background. My training is in theoretical chemistry and protein crystallography in the old days of protein crystallography. And when I was at the Cancer Research Institute and subsequently at Mount Sinai School of Medicine, I was recruited by Amico when they were in the biotechnology field or exploring biotechnology to head up bioinformatics with a joint venture with Stanford called IntelliGenetics. From there, we launched a DNA diagnostics company called Visus, and part of my responsibility there was looking at the original HER2 test that is well known now in breast cancer and other cancers. But at the time, there were no drugs, and part of my modeling expertise was being applied to figuring out how to get the FDA to understand that using the test, we could change the practice of medicine, identify patients who were either being overtreated or undertreated by adding that single test. That actually led me to come to the understanding that we actually didn't understand breast cancer, as an example. And one of the opportunities I had then was to move into the pharmaceutical industry, first at Wyeth as director of bioinformatics, and then eventually to Roche as global head of computational biology and genomics. And I found that we still didn't understand disease. And a bit of frustration was that we weren't spending time trying to understand disease as much as we were spending time developing drugs. And I went back to academics, actually, and found that academics still wasn't working in that direction. But I was recruited to run a breast cancer center for the department, funded by the Department of Defense, that was joint with Walter Reed out in Windber, Pennsylvania. And in that capacity, we worked from the clinic back, from surgery, pathology, into genomics, tissue banking, proteomics, and designed a personalized health record. And that led me actually to launch what we now have has been involved into IPQ Analytics. And the focus there, as it's been through most of my career, is really understanding disease, but understanding it not just from the molecular perspective, but from the clinical perspective, from the patient perspective, from a systems perspective. And that's really what we're doing now.
So let's try to break down that concept. You mentioned a few times that we don't understand disease well. We understand breast cancer well. flaws with understanding disease? Let's pick a certain condition like breast cancer. What's our flaw today in understanding breast cancer?
Well, the thing that we have to recognize is that physicians have to be very operational, and they have to deal with the patient coming in through the door, the tests that have to be ordered, reimbursement, interpretation, family interactions, and all types of support systems. That doesn't necessarily give them the chance to ask the longer term, what I call root cause problem questions. The luxury I have, or I've taken, is to try to work with clinicians to not in any way try to challenge what they do and what they have to do, but to find out what are the questions that would help them do it better. How confident are they in the concepts of their diagnosis? Do they think those categorizations are adequate to come up with the right treatment? Or are they there because we need to have something on a claims report for insurance purposes? The patient doesn't like to walk out of the office with an unknown diagnosis. They'd like to at least feel that there's some knowledge of how they're going to be managed. And yet we don't have the luxury of doing that deep research, that deep probing to find causes very effectively. A lot of my academic colleagues who are excellent researchers are taking typically very narrow perspectives on very detailed dives into the problem. But it also really needs a more holistic, comprehensive view of the whole ecosystem.
So it sounds like this concept of narrow versus expansive set of drivers, this concept of short-term causes versus longer-term causes, those are both at the root of what we're trying to shed light on.
Mm-hmm.
Analytical too. So let's walk through an example. Let's imagine a female patient, since you do a lot of work in women's health, goes to the doctor. That doctor who has the short-term view of drivers of certain conditions, what is that doctor going to look for, and what is that doctor going to miss relative to your perspective of much more holistic, much more long-term? What are the tangible sort of conditions or variables?
I can give you a fairly discrete, specific example. When a physician's at this point really diagnosing a patient with breast cancer, there are four main subtypes, and the subtypes are usually defined by three markers, biomarkers: estrogen receptor level, progesterone receptor level, and the HER2/neu. So those are three tests that are typically run. Based on the outcome, the patient's breast cancer may be stratified into one of those conditions, and then the guidelines talk about how to manage the patient based on that. The drugs are developed based on that kind of classification. But the reality is, the way it's applied is you establish a threshold for whether something is estrogen receptor positive or negative. You establish a threshold similarly for progesterone receptor levels or for HER2/neu levels. And the real situation that evolves is that different institutions not only may test for those things differently, but set the thresholds differently. And so what we find, say, in a patient in a condition that's very difficult to treat and manage, triple negative breast cancer, where technically we believe the patient is negative in all three of those different tests, what we find is patient may not be triple negative in one center, even though they're diagnosed that way in another center, either because of the tests involved or because of the thresholds. We've also come to learn that something like HER2/neu should not just be positive and negative, because now we should differentiate between low and ultra low levels, and we're finding similar things in the ER and PR. So those are complexities that need to be researched much more deeply, but they don't necessarily translate to immediate practice at this point. And the practicing physician is trying to come up with guidelines and things that can be applied very quickly and be fairly accurate as they can be, but not these nuances that we're starting to understand. And those are the kinds of things we're studying.
What do these studies look like? How long do they play out over? Who's engaging you for the study? Are they government grants?
Well,
Hospital grants?
that's again an interesting question. What I found is we've looked at conventional funding, which would be NIH type funding, but we've also been told that while what we're doing makes a lot of sense, it's also somewhat disruptive. And as a result, we don't necessarily fit into the conventional guidelines that reviewers are using in some of these panels. And similarly, when we're talking to, say, a pharma company or an investment group, we find that they have a shorter term view of what they would like in terms of turnaround or very specific direction they like us to take. Whereas we're trying to really understand the process. I call it more of a discovery model. We're trying to understand where the edges are very rough, where they don't match, where the gaps exist, and not necessarily that we're doing this to establish statistical significance because we have an enormous population, but what are the rocks that should be overturned? And if they do show something, then we can set up a study with the right statistical constraints to evaluate the significance of it that way. But if we only rely on having large populations, a lot of these things will never be turned over and may sit by the roadside and not be incorporated into our learning experience. So one of the things we've had to do in setting up IPQ, which has been focusing as a consulting group, providing services, what we call modeling as a service, is create a nonprofit side of IPQ, which can look at these kinds of problems that we're looking at in women's health, but do it in the slow, deliberate manner we would like to do it. Because again, the general concept is we want to move away from correlation to causality, because causality is really fundamental to being able to come up with potential prevention as well as better treatments.
What are the other conditions you're focused on besides breast cancer?
Well, what we're actually focused on is a woman's development over her lifetime. So our two main areas, one is looking at infant and maternal morbidity and mortality, which is a major problem globally, and in particular, things like hypertensive disorders of pregnancy, such as preeclampsia, eclampsia, looking at endometriosis, and looking at PCOS, looking at conditions that affect the actual pregnancy. And at the other end of the spectrum, we're looking at how women actually go through perimenopause and menopause uniquely, but we don't have any data on that. We know anecdotally that women experience differences, but we don't have anything to understand if there are maybe some common paths. And so we're building the models starting actually with Menarche to understand a woman's journey from menarche all the way through to menopause, which then gives us the potential to evaluate an individualized risk for breast cancer or an individualized risk for cardiovascular disease or an individualized risk for osteoporosis. So how do we really develop it as personalized medicine as we mean it, not purely a genomic marker?
What are some of the variables as a female patient goes through that journey? What are some of the variables that are driving different postmenopausal outcomes?
Well, again, we're doing this in a discovery manner. So when I talk about what we're looking at, we're talking about the kinds of data we're collecting, not necessarily data that's available. So I'm not going to say that these are the factors that are driving it, but they're the kinds of factors we're looking at. One of the factors we're looking at is that we know while we're having success in treating breast cancer patients, we're having earlier diagnosis of breast cancer patients, and women are living longer who are diagnosed with breast cancer. What we're only just really recognizing is that the incidence rate of breast cancer is continuing to increase. It hasn't abated to any extent. So the question is, if we really want to drive prevention rather than just early detection, we need to understand why that incidence is increasing. Some of our models are for perimenopause and menopause are built with that concept in mind. So one of the things we're looking at is we know that globally, the age of menarche has been going down. So when a woman enters puberty is younger and younger. We also know, again, globally, that the average age of the first pregnancy is going up. Now, what we've done in the past to evaluate risk is we've incorporated the age of menarche or the age of first pregnancy as factors in a correlative analysis. But what we haven't really dealt with is the fact that is potentially the number of menstrual cycles that a woman goes through in that time course, which is increasing if those 2 points are also changing, as I noted. The reason we think that may be important is we know that in general, nulliparity is a risk factor for breast cancer. Now, many people think nulliparity means never having a child, but what it actually means is never having a live delivery. And if we look at the age of menarche going down, the age of first birth going up, the period in between is therefore a nulliparous period. And we are increasing that slightly, and that's increasing slightly. That's an observation, that's a correlation. It's not causality, and that's the kind of thing we're collecting data on. Similarly, when we look at pregnancies, what we look at typically is the age of the pregnancy, how many pregnancies, sometimes how far apart the pregnancies are. What we tend not to consider is what was the gestational age at time of delivery. And the reason that can be important is that when a woman is pregnant, her body is basically acclimating for a full-term pregnancy somewhere around 38 to 40 weeks. If she delivers prematurely, which now we can consider anything from commonly about 22 weeks on, if we look at her exposure to hormones, both those produced by the fetus and the hormones produced by the mother during the pregnancy, she may only be exposed to less than half of the normal hormone levels. Does that impact her perimenopausal transition? And does that impact, therefore, her risk for breast cancer and these other postmenopausal diseases? We don't know, but we don't have the data to be able to evaluate. And that's the kind of thing we're looking at.
So let's talk about two follow-up questions. So one is having with the data, which I'll leave second. But the first is about what to do with the results. So it sounds like IPQ plays a role in assessing, analyzing large data sets to look for correlations, not necessarily getting to the point of saying there's causality. So your goal and your mission is to look for correlation. And you're looking at a much more expansive view, a much broader range of variables, highlighting great transparency to these correlations. So let's imagine you go through a study, get to correlations, so whether it's the hormonal levels, whether it's the gestational period, whether it's sort of age when someone's having pregnancy, frequency of pregnancy, whatever these these variables are. You've identified a correlation. How do we take that correlation and apply it to real world outcomes? Are you hoping that a pharmaceutical company will take it from there? Are you hoping that a large women's health OBGYN organization will take it from there? What's kind of the next step after IPQ has identified correlation?
Well, we're working collaboratively, not just for the delivery and application of our results, but actually for the generation of the data necessary with groups internationally. So we're working with groups here in the US, we're working with groups in Australia, in Italy, and we've had some success in the past working in China and India. So we're looking, and in Mexico as well. So we're looking at how broad the data sets are that we could start to access, but we're also doing that because we're interested in the reality that we know exists with underserved populations. And so we know that we can't just have a single population group to be able to really understand the underlying mechanism, and that it may be different for different groups, but that's important for understanding the causality or approaching the causality. So we are working with them for data acquisition. I just had a discussion with an international network this morning about applying our study through their network. And then at the end, we're working with these collaborators for them to potentially apply them in direct studies, clinical studies that would be what we would call a normal clinical trial. Can we take these algorithms and apply them prospectively, not just retrospectively? So that's the conventional way that we would be doing hypothesis evaluation, that we would test it out with larger populations.
What are you hoping for? So let's say the clinical study goes well. What are you hoping to change in the market? So better preventative care, just different care patterns that OBGYNs, when they're meeting with their patients, will have different protocols and different questionnaires that they're thinking, what does that state look like?
It's a combination. We would like to be able to provide clinicians with the right questions to ask rather than burden them with all kinds of questions where we don't know what data is really important. We would like, and we are implementing the kinds of studies we're doing in a manner that can be carried out irrespective of whether you're in an academic setting or a rural setting, that an individual can fill out the questions on these studies sitting at home, potentially as an app on their phone, so that we're trying to reduce the barrier to access, at least our initial studies. And then potentially as we go forward and get to more and more complex studies, that will require us to further modify that and not have it quite as broad, but it will be much more detailed and focused when we're doing that. We'd like to be able, especially as an example in our menopause study, I think most people would recognize, and women recognize it for sure, maybe men aren't quite as aware, that women tend not to be able to get the information they would like from their gynecologists, because the gynecologists haven't been trained necessarily as much as they would like to be trained, because the data is not available. And so women tend to develop networks of friends and colleagues, and through those interactions, get their information besides what they get on the internet. The challenge, however, is, and this is a central focus of our approach, a core element, we treat disease or any of these conditions as processes, not states, which means they evolve over time. And why that's important is that in a typical network, as I just described, a woman will ask her friend about her hot flashes. 80% of all women going through perimenopause and menopause have hot flashes. So one of the common things is, did you have hot flashes? How bad were they? How did you manage them? The challenge, however, that isn't being incorporated with that mechanism is that your hot flashes and your friend's hot flashes may not be the same. And they may not be the same because they're one symptom of a journey that may last 7 to 10 years. And so you're taking that one symptom and trying to get information about it because that's your best source right now. You don't have an option. And yet we want to know that there are 62 other symptoms that can potentially impact or show up in an inventory of menopause, perimenopause. Which of these other symptoms are you also presenting? Because they're going to impact the hot flashes and they'll interact with that. And maybe the treatment that worked for you won't work for someone else because they have a different set of these symptoms, additional symptoms. And so along the way, while we definitely want to improve the ability not just to predict breast cancer, but the subtype of breast cancer you may actually be susceptible to, what we'd like to be able to do is provide better insight for women as they enter into this perimenopause, menopause transition so that they know what to expect. They have a much better idea. Obviously, everyone will be individual. There will not be absolute tracks and paths, but to have an idea that palpitations at certain stages may be normal and you don't have to run to a cardiologist for examination who doesn't understand that you're in perimenopause can be much more comforting than the alternative. And so we think this is something as a service, as public value would be important to be able to put into the public domain.
That was like an iceberg where the tip is out above the water. It sounds like a lot of medicine focuses on the part of the iceberg that's above the water, so the flashes.
They actually published a paper with that analogy.
Beneath the surface.
Yeah.
Almost comorbidities or other variables that are at play. So I get the outcome, the target goal is to understand all of the structure beneath the water, the rest of the iceberg, the other 90%, and to drive more informed decision making, better sort of thought process about how clinicians are diagnosing and thinking about preventative care and democratizing care. I think that was a big part of what you mentioned, which was interesting, allowing the right questionnaires to make it to underserved populations, whether it's geographically underserved or economically underserved, both. Now let's talk about where are we in the life cycle of getting to that outcome. So are we in the first inning, fifth inning, ninth inning of being able to understand this large data set to get to that outcome that you're just.
Yeah, so where we are is we've been interacting with all of the international data repositories that we can access. In the US, it's all of us. In the UK, it's the UK Biobank. There's a longitudinal women's study in Australia. There's the SWAN study. what we find is what I call the difference. When I tell people we're doing computational work, nowadays the very first question they ask is, are you using AI and ML? And what I have to explain to them is our focus is problem solving. And if the problem merits the use of AI and ML, we use it. But that's not the tool we come in to apply. We come in to focus on the problem and figure out the tool. Now, why that's important is a lot of the AI/ML approaches are based on big data analytics, and they're looking for more and more data. And what they frequently don't always recognize is the data that's available was collected based on some model. That's why that data was collected. That means there is some bias potentially in the data that's been collected, but you're never going to be able to go beyond the model with that data. You'll find new patterns in the data, but not new knowledge in that data beyond that. We call that data-driven modeling, and we talk about that a lot. What we're trying to do is what I call model-driven data analytics. And so the example I gave you with the null parity period and so on, we start with the clinicians and the patients to try to understand what the unknown unknowns are as much as we can, or at least define some of them, and then try to establish a model around that, and then look to see if the data exists. When that data doesn't exist, that's when we initiate a study to collect it. And what we've found so far is that a lot of the data we would like to have that I described to you doesn't exist in any of those known databases that are currently available. That's when we set up our own studies. We have one just being launched in the US and a counterpart in Australia right now. And we're discussing with this network expanding it internationally.
How do you think about defining the known unknowns? So you've mentioned so many different variables, from, again, things like hormone levels to frequency of birth to age of birth. How do you define, and you're talking about over in a woman's entire life, how do you define the known unknowns?
Well, over a woman's entire life, we're going to be talking to gynecologists, GPs, obstetricians. We're going to be talking to psychologists because we also have to look at postpartum depression and conditions like that. So we're talking to clinicians at all different levels because each one has their own specialty and looks at the same patient through a different window. And the way I describe it as an analogy, it's like having a house and having everyone looking in a different window and describing what they see, and they're all ignoring the fact that it's a house. And what we're trying to do is say, we know it's a house, we have incomplete views, but we're using methods like knowledge graphs and a novel approach that we've been developing to augment existing knowledge graphs that allow us to start to approach these unknown unknowns and incorporate them and build it from that house model, not from the window view.
Got it. So it sounds like a lot of the known unknowns are known by the individual specialists. It sounds like the two key roadblocks are, one, creating a holistic picture across those specialists, and two, in a lot of cases, the data doesn't exist in these databases, so you have to develop these bespoke studies to be able to get at the data. Is that a fair summary?
The other piece though that's really critical, and I found this out when I was running the breast center jointly with Walter Reed, is how to interact with clinicians so that you can gain their trust and have them understand you're not trying to challenge what they do. I'm the last person who could challenge a clinician in terms of their practice. I'm not trying to do that. But what I'm trying to do is let them relax a bit to think about the things that they're not as sure about okay, where do they have uncertainties, and ask the questions why. How confident are you in your diagnosis? Would it help if you had something that stratified that? I mentioned preeclampsia. We talk about preeclampsia as if it's a condition, but it's multiple conditions. I use a reference called Up to Date, which many clinicians use to provide background information. And when I go in there and I look at the symptoms for diagnosis, and I see that it lists 10 symptoms and says that a patient only has to have 3, that immediately says to me, these patients are going to be heterogeneous with this diagnosis. And they're not all going to be the same, because all they had to do was have some 3 of these, and they may not have the same 3. And therefore, they maybe don't have exactly the same condition and need to be considered differently. But that becomes a challenge because we don't have the data to look at that. That's where we come in and try to tease those things apart using different kinds of novel algorithms.
Look, I want to sort of step back, and now that I have a pretty good sense for what you focus on and how it's applicable and what the tangible sort of outcomes and target objectives are, I want to step back and think about a couple of macro questions. So the first is one about international healthcare. You mentioned Mexico, Australia, United States, UK, China. So you've had broad perspective about how different countries are thinking about this type of data analytics exercise, how different countries are thinking about and structured in terms of managing patient data, how organized are they, how good is their database. What comparisons and observations do you have in different countries? Is there one that stands out as being ahead of the curve in this area? How does the U.S. compare?
Well, I guess the way I would compare it is not necessarily country to country directly. I would compare it more, do you have nationalized health care or you don't have nationalized health care? When you have nationalized health care, you have the ability to have a general population database. Maybe not 100%, because some people always opt for private care. But when you have a distributed healthcare system like we have here, we don't have the ability to integrate the data very effectively. And even when we tackle very, very large projects, like we did with COVID, like we do with a lot of other conditions, we're stitching together data from a lot of different sources. And like I explained in the triple negative breast cancer example, the diagnosis may not be applied the same. The guidelines that are published, say, by a professional organization in oncology like ASCO, may be applied differently at different institutions. They don't have to be applied identically. And as a result, how do you put that data together can be very challenging. That's one of the challenges we have in the US. It's up until now been very limited in terms of where you had a sort of concentrated uniform data or healthcare application. Basically, it's Kaiser Permanente through their network, Geisinger, which is now part of Kaiser, and TRICARE out of the military. And it gives you somewhat of a set of standards that can be applied within those groups. But each one, the max is about 8 to 9 million people, I think, covered in each of those out of over 300 million people in the country. So we're not really representative. When we go to some of the other countries, we work with the National Research Council of Italy. It's a nationalized healthcare program.
Is Italy one that stands out as being the most organized on this topic?
Italy can be. The Nordic countries really have the best collections of data because they have been collecting data even, say, preterm, pre-pregnancy healthcare and going on beyond delivery into early childhood. So the best data repositories we found are in the Nordic countries.
So it sounds like from a data perspective, the U.S. suffers from maybe some data silos relative to some other countries. Countries as positive outliers. What about in terms of in the U.S. in terms of structured and organized collaboration outside of data? So do you have a clear counterpart to go to the association, the OBGYN association, or some body within CMS that you're working with to at least tackle these data challenges and questions that you're looking to address?
We haven't approached the professional societies yet. We are working more with some of the healthcare networks that exist that have very far reaches in different states. Those are a bit easier to start to work with and have longitudinal data.
What's an example of one of those networks?
Well, we are in discussion right now with Christiana Healthcare in Delaware. Christiana services most of the state of Delaware and then therefore has healthcare that when someone may present at the cancer center, they've probably been a patient somewhere in the Christiana network through their whole life.
But it sounds like that's a conversation that's one-off in the sense that you have a relationship with them. They may have good data. They may have an interest to pursue and study this question, but it's nothing that's top-down mandated that, we are going to go study this condition and let's make it happen.
Well, we work collaboratively with them. So obviously one of the things we want to do is add value to problems that they see that they have of high priority. And so there's not a fixed indication that we would not work with them if they wanted a certain condition. Sort of have the ideas, what are the most prevalent conditions that you have concerns about? Because they're going to differ for regions, states, and so on. And what about the data collaboration on the problems we're starting to look at as well? And there's usually a significant overlap.
Very good. Well, look, I want to thank you for your time, Michael. This is extremely interesting. It's we have a lot of technology companies on this podcast, and so I think a lot of the innovation that we study in the market tends to do with automation, the application of AI. I think this is a very interesting and different approach to innovation within clinical care and the use of technology and data analytics to drive a more informed healthcare system. So I commend you on the work you're doing. I really appreciate the insights you provided today, and I look forward to keeping in touch and seeing how your studies continue to play out.
Thank you. And, to a large extent, we're dependent, the way I explain it to people, we're dependent on those companies that are developing the technology. So we don't have to, but they have a commercial outlet, and that will drive them to develop it. And then we can borrow it or apply it or modify it to address the problems that we're seeing.
Very good. Very good. Thank you very much, Michael. I really appreciate it.
Thank you.
Take care.